Good afternoon. Welcome to this FETL broadcast. I'm Paul Granger from the Centre for Education and Work at UCL, and I'm here to introduce Dragana Ramsden, a recent FETL and UCL Fellow. Dragana's publication, Collaboration and Leadership for Improving Mental Health and Wellbeing, which she wrote during her time as a FETL Fellow, is a fascinating insight into two major issues. First of all, contrasting professional cultures, and secondly, how leaders can influence those cultures to promote change. As the broadcast proceeds, please submit questions. We'll leave good time for them at the end. Please say who you are, and then we can respond to you. So, Dragana, over to you.
Thank you, Paul. I'm absolutely delighted to be able to share the findings of my research. So my presentation will consist of 5 sections. I will begin by giving an overview of the research, methodology and participants, to move on to the context that actually prompted my questionings. My findings will be part of the 3rd section in order to move on to conclusions, some recommendations, and hopefully there'll be some questions at the end. So the methodology I used involved 108 participants and included online surveys, focus groups and semi-structured interviews. I had professionals from adult community learning, primary care and mental health services, as well as adult learners with experience of mild to moderate mental health difficulties. I was greatly inspired by the first year of my leadership experience within Community Learning Mental Health project. The project took place between 2015 and 2017, and 62 local authority areas took part in it, involving 23,000 learners. And the project tested whether short part-time community learning courses help people develop strategies to manage their mild to moderate mental health problems. And we are anticipated with great excitement what the evaluation will say, not only about possibilities of our further work, but also about the outcomes. So what is the context that actually inspired my thinking about collaborative working? I will begin with this slide, which is from Mind's publication, aimed at clinical commissioning groups, simply because it shows at least 3 well-evidenced facts. First, the importance of social issues in people's health. We have a graph here showing that nearly a fifth of a GP's appointment is spent on social issues, for example. Then this slide also shows inequality of access to support, with only 67% of rough sleepers being registered with GP practices in comparison to 98% of general population. And finally, something we hear about a lot is how stretched primary care services are. So for most of us working in adult education, you'll say, well, hold on, we are already reaching out to people with difficulties of accessing the mainstream services. We know, evidence shows that we have, that adult education has got impact on people's well-being. And we know that adult education supports people to develop strategies to cope better with stress and live more enriched lives. So 2 and 2 was simply not adding up. Looking further into policy, it appears that mental health policy related to education at the minute goes up to the support of students up to the age of 25. So it shows that the priority for learners over the 25 is not as strong, or it doesn't exist at all. And again, if you look closer at practice, health services are putting a lot of emphasis on preventative and collaborative approaches. They're doing a lot of work on place-based interventions. And at the same time, our sector is preparing for devolution. We know that we depend on collaborations and that we are very good at it. And that adult education does have impact on people's health and well-being. So are we sharing the same problem? Are we letting our communities down by not maximizing our impact on the communities and our expertise. So this prompted my research questions. The first one was about testing the viability of this collaboration. So what are the benefits of this possible collaboration? And also, do stakeholders share the same values? It became very apparent very soon, talking to the research participants, that there was a very strong sense that the collaboration has got more chances to address adults' needs in a holistic way, instead of relying on individualistic or medical approaches. That collaboration can give people a more external resources for self-management positions. Collaboration could maximize access to community resources. So it became obvious very soon that the social value that adult education brings would help reduce inequality in health, because it can address social determinants of health. And in terms of values, all groups of stakeholders, so the professionals working in adult education, those working in primary care mental health services, as well as learners, shared the same values. Equality was very high on the agenda. The quality of service, respect and dignity, and the need to work collaboratively. I'm sure nobody will be surprised that students felt very strongly that they wanted to be a functioning part of a community, not defined by their health conditions, and that the classroom felt like a safe place, and that they wanted to be listened to. So far, so good. It seemed that there was a lot of basis for actually working together. So the next issue that I looked at was, okay, so if we are agreeing on the values, and if we believe that there are benefits of our collaborative working, how could the collaboration actually look like? What is our shared vision? One thing that became obvious very soon, that there was no expectation from research participants for adult education to do anything else but do what it already does well. And that is to promote mental health and well-being, to continue building people's resilience, and to continue tackling inequality in access to services. And the key guiding principles for this shared collaboration or shared vision seem to be the importance that this collaboration sits within a bigger system. So the system that supports, again, holistic needs of people, but at the same time, that allows flexible local models. Secondly, it was important that each partner, each collaborator has a very differentiated role. And finally, that this vision of working is co-produced with local communities and learners. So that all felt very promising until we got to the third question. So if this vision was to be realized, what are the key leadership characteristics needed to make such a vision the reality? And I looked at that from asking the question, so what is a leadership challenge? And this is where the real problems began, because the participants were coming up with a range of current challenges that are standing in the way of this type of vision. These that you see on your screen are just some of those that participants mentioned, and included lack of joined-up thinking at the national policy level, lack of policy for lifelong learning, short organizational memory. Just to illustrate that, based on the report published by Norris and Adam by Institute of Government, in the last 30 years, there have been 48 secretaries of state, 28 pieces of legislation, and 6 ministerial departments related to further education and skills. So showing weakness to plan long term, and also to take lessons from a variety of projects that happened before now. Obviously, other challenges that research participants mentioned included challenges related to their own organization, to their own workload, to their own local circumstances. I was able to group the challenges into a few groups that you can see on your screen, which actually showed that challenges and solutions belong to different parts of the system, and it is really not clear who takes responsibility. Challenges are spread, but they are interconnected. So, for example, a central government policy impacts on our work in individual organizations, or a lack of policy impacts in the same way. And what seemed obvious is that leadership of one part of the system, it is not in charge of another part of the system, but it still operates within that. And for me, most importantly, it seems that the sector itself is part of this challenge, but possibly part of the solution too. So building a fairer or healthier society seems to be a responsibility of all parts of the system. So, what do leaders need to do? And these are some of my conclusions. Participants refer to the need for leadership to work simultaneously with multiple stakeholders, but in a different way, depending on organizational context, depending on local context. So, for example, leadership's responsibility would be to empower local communities to have an equal footing in deciding how collaboration actually works. Or leadership's responsibility, it is to empower its own organization to be more effective in supporting health and well-being of its own staff and its own learners. Or it could be influencing local decision makers on how AEB funding is spent. Or it could be influencing policymakers by sharing a compelling narrative about the purpose of adult education and the outcomes of adult education. So, key leadership requirements are primarily for leaders to build and maintain relationships and to learn through these relationships by being committed to equality. That seemed like key requirements for leaders in order to function in this dimension. So, conclusions referred to three key narratives. First, the need to broaden the narrative related to mental health and well-being. Mental health and well-being is not just about mental health difficulties or mental health illness. It is about holistic approaches to adults. And if you rely on a medical approach, you can't address social determinants. When it comes to purpose and potential of adult education, it is about ensuring that there is a compelling narrative about the impact that adult education already has. And it seems that the policy and funding context does not support ACL to work to its full potential. And finally, requirements of adult community learning leadership are really focused on relational skills and a whole system thinking. So the conclusions are that leaders within adult community learning context need to recognize their own responsibility and accept they don't have all the answers. Being able to articulate the purpose of our work and the outcome of the work, broadening the narratives around mental health, so medical and social approaches, or broadening the narrative about adult education, skills, and mental health and well-being. And reaching out, learning, mobilizing, and empowering. And you can see just some of the recommendations for adult community learning leadership on the screen, related to representations in local health and well-being boards, or developing whole organizational approaches, or investing in the collection and analysis of robust outcome measures, etc. But I must add that the publication itself contains recommendations for all parts of the system, including training organizations, including NHS England, central government, etc. So, this is the time for your questions. If there are any.
Absolutely fascinating, Dragana, and really a major, I think, contribution to our understanding of the role of leaders in reaching out and crossing the boundaries in which they find themselves. I'm going to show my age here. 25 years ago, we had this thing, incorporation, where colleges left local authority control and went into a centralised funding system. And at that time, colleges were constrained to focus on qualifications. We lost a lot of adult and community courses, and we were told it's got to be about qualifications, it's got to be about skills for employment, and we lost sight of the all-round development of young people. Would you say from your research that you sense a change in the national ethos, a return to a more inclusive approach to education?
Well, without an attempt to show my age, I would say that I feel that the key policy drivers that remain are economic and social mobility, young people and technical skills gaps. So between 2004 and 2010, NIAS organised with the NHS regional and national partnership work in order to improve social and economic inclusion of people with mental health difficulties. But that initiative stopped in 2010. So there were initiatives before today, but we might be facing some increased inequality, not only social and economic, but also health inequality at the minute.
Right. Because I suppose there's been a renewed emphasis on the social inclusion responsibility of colleges, which might support the line of inquiry which you've been following. But interesting, yeah. It occurs to me that overall professional activity is becoming increasingly specialist. That we need so much more expertise in a narrow field. So can we really expect educators to be mental health and social care workers also? Or if not, how can we get that collaboration to work?
There is no expectation for adult educators to do anything else but to do what they already do. They may need support in skills, in funding, in policy type of support to do the work they're already doing better, or to maximize the impact. But there is no expectation based on the research that the role of adult education changes. I must say that from the research, primary care mental health service staff were very strong advocates for adult education, because adult education maximizes people's access to community resources that are not necessarily provided by the state. So it is not about changing the roles. It is just maximizing impact through collaboration.
Yep. No, I can see that. But some would claim that the cultural divide between the NHS and adult community learning is just too broad. Some of coming from such different backgrounds, they have different professional conventions. How would you go about reconciling these two silos?
I think the first point and first step is to recognize that we may be sharing the same problem. We are working with the same local people, and to recognize what benefits there may be for each sector to work collaboratively. I wonder whether the same question is being asked when it comes to the collaboration between the sector and employers, for example. So seeing each other's perspective and understanding what joint problem we are trying to address by complementing each other, I think would be the key thing. And Absolutely, it's not going to be easy. And it hasn't been easy for any of our colleagues who are already working remarkably well with their local health services. So just seeing each other's perspective is a good starting point.
Okay. Well, let's turn to some of the questions from the viewers. And we've got one here from someone who prefers to remain anonymous. And the question is, the leadership of learning is clearly the most important part of their role. Do these learners require a different approach to their learning?
I think we need to recognize that health and well-being is part of each of us, and that deteriorating well-being can be a cause and consequence related to mental health difficulty. I think we need to see the people's needs in a kind of wider concept. We are not talking about supporting in a very different way a very different type of people. I think it's recognizing that people's needs are holistic and people need holistic approaches. So people may need more confidence and more skills to be able to provide appropriate support and to feel resilient and to enable resilience of others. But it is not about secluding or working in any different way. It's basically strengthening the way that we already are working.
Interesting. Thank you. Well, we've got a good question here from Rob Nash from Hampshire County Council. How do we balance the expectations of the Common Inspection Framework and those of Ofsted around attendance and achievement with the needs of learners with mental health? E.g., a learner is enrolled on the ILR, but then has a period of MH, meaning they can no longer attend consistently. How do ACL providers meet key performance indicators relating to Ofsted and the Common Inspection Framework, as well as those of mental health learners?
I think going back to the research and my key point around we need to learn from our learners, and we need to involve learners in developing our approaches. I strongly believe that if we have the curriculum that is right for the learners, and if the learners are part of defining that curriculum, that we will jointly have strategies to support learners in an appropriate way. Personal development and well-being and outcomes for learners are already requirements of Ofsted, so there's no difference there. It's just understanding how we have a tailored curriculum or tailored ways of supporting people that enable them to achieve, attend and succeed.
Okay. Well, we've another interesting question here from Simon Beer from Haringey Adult Learning. What links, if any, did your work throw up between mental health wellbeing outcomes and social integration outcomes for adult learning?
The research really pointed out the difficulties of having a robust measures that are shared across the board related to the tool, because a lot of providers have different ways of working depending on their own assets or needs in the local area. What is clear from the research is that social determinants are incredibly important for health and well-being. So by addressing those, they directly or indirectly are related to people's health and well-being. So I think there is a scope to further look at this and find a way of measuring the link between the two.
It's an interesting outcome of your research. Kat Frakes says, it's not that different. It's about people, isn't it?
Absolutely, and I wish more people said that. It is about people. It's not about having one approach and defining people by any of their characteristics. Absolutely.
I have another anonymous comment here which says, absolutely wonderful. It captures everything we experienced during the project and so much that went before. How do you think we can influence policymakers to invest in adult and community learning?
We need to be able to articulate what we stand for. We, I mean adult community learning providers.
Right.
Adult community learning providers are involved in a variety of outcomes, in parenting outcomes, well-being, skills and qualification, economic outcomes. And if we are not able to articulate what we do, we can't expect anybody else to understand it. And I think also being able to share the outcomes with our health colleagues and our communities, so we share the same compelling narrative, is a key. And we have a chance with devolution influencing how the budget is spent or how local policies are made and what outcomes actually are used to measure what we do. So one needs to act simultaneously with different stakeholders here, depending on local circumstances.
Well, there's a challenge. OK. Louise Weller from Bristol says, break down the barriers between the health service and community learning. By signposting patients to community learning courses, it can reduce the amount of counselling sessions they may need or be an addition to the support they're already receiving. In
partnerships that exist now or that have been tried before, there have been a lot of challenges related to who does what and what impact the collaboration has on each provider. I think I'm not disputing that there will be challenges in ironing out who has got which role, but I think the key point is actually sharing the outcomes between health, education and people involved. So the arrangements need to be tailored to the local conditions.
OK. Right. Well, Andrea Birch from Faircroft College of Adult Education asks, what is the status of the evaluation and findings of the community learning mental health pilot, and how has this been considered within this research?
I wouldn't be able to confirm when the evaluation will come out because I was just one of the leaders in the project, but I hope that it will be coming out soon.
Right. Well, let's all hope
yes,
so too.
Absolutely.
Yeah.
I think that could inform our collaborative working, but it may also help adult education leaders become more confident to articulate what the sector stands for and what difference it actually makes.
OK. There's one here from Patricia Dillon-Russell, Kent Adult Education. We're working with the NHS to support their recovery college in Kent. It's about building collaborative working relationships. It's an interesting thought, isn't it?
Yes, I mean, a lot of providers during the Community Learning Mental Health Project worked with recovery colleges and a variety of providers in a very different way. So I think that richness is wonderful. But we are within the system that nationally may not be entirely coherent. So enabling others to work with collaboratively with other partners would be important.
OK. One here from Tara Rudiani, who writes a question from her own consultancy. How do you develop in practice the tailored curriculum that you mention that will support attendance and progression?
Working closely with learners to understand their needs, their aspirations, working in co-productive ways with learners will support all of us to build the right progression pathways. So it is just starting from the point that we don't know all the answers, and consulting people who may have answers to some of our questions would be the key thing. Obviously, working collaboratively across the areas, so different partners may be complementing each other, I think would be important in developing curriculum in that way.
Thank you. Katina Barrett from Education and Intersectionalities asks, there's plenty of evidence from the NIACE LSC CSIP work and more recently research, for example, at Highbury College, that attendance rates for learners with mental health problems are not necessarily lower than for learners who do not have mental health problems. One of the strengths of FE is meant to be its flexibility and responsiveness to learners' needs.
Absolutely, and I agree with that, and it kind of goes in line with the previous question related to how we support learners. So as long as we have a flexible and tailored approaches to our work, we're there.
Okay, Patricia Dillon-Russell's come back to us from Kent Adult Education. I agree delivering mental health awareness through adult ed is a positive step. Did you find a lot of providers delivering this within your research?
Yes, nationally there have been projects that are working very successfully in their local areas with mental health providers. For example, Northampton has been contributing to talking therapy's return outcomes for 8 years now. There's Hackney Community College, there's Wirral, there's Blackpool, Blackburn. So they are very successful collaborations nationally, and learning the lessons of good practice and what worked and what may be challenging would be a good way to understand how we make the next steps.
Thank you. Paul Tibbets from Civica asks, would the AOC Colleges Week might be a useful campaign for ACL providers to get behind to appeal for more funding?
Any support that this agenda can get would be greatly welcome. I think developing a kind of whole system thinking about mental health and well-being and our learners in a very holistic way is important. As I said earlier, it's not about a binary medical and social, and it's not about skills versus well-being. We are dealing with the human services, with people who need holistic approaches. So any support, please.
Richard, also from Civica, asks, what learner data does Dragana's college collect relating to students, and do they really share this with the relevant staff? Any tips?
During the Community Learning Mental Health project, all research sites, were using internationally validated data on mental health conditions and well-being, which talking therapies already use. So this was used in the project and will be forming part of the evaluation related to whether short community learning courses help people develop the right strategies. So this is the data that was used in that project. I know that different providers use different data, so that will be also part of the challenge of moving this collaboration further.
Just to move on to a question which has come on anonymously, do you feel these partnerships require effective referral pathways between adult learning and primary care services for if learners need intervention from health, as opposed to using safeguarding processes to highlight need if this occurs?
I think my point really through this research is that local collaborative arrangements need to be based on local needs and involve both sectors and local communities to decide what works best in that context. I wouldn't be going into a detail of that particular collaborative arrangement, because that will really be dependent on the collaborators involved. We have during the project, there have been issues that we needed to think through around referrals, around our own ability to support learners, around safeguarding, etc. But that wouldn't be any different to how we normally work with learners.
Thank you. I have a question here from Chris Truckle, who's from Blackburn and Darwen Borough Council. We've had some great success with our local NHS IAPT service by building our understanding of each other's remit and recognising how we can work together. However, so much is dependent on the individuals involved feeling confident to work together and to see the bigger picture for the learner. It would be great to see a national, coherent push to allow more collaborative approaches between the sectors to be developed.
Absolutely, I can't agree more, which is why in my conclusions there are recommendations for the central government, for NHS England, for public health. I think responsibility to build fair and healthier society lies across the system. So that's a key. So thank you for pointing that out.
Yeah, it's a great point, isn't it? Yeah. Right, I have a question here from an anonymous chair. Governors set the work and tone in FE. What message do you have for the governors of colleges in relation to developing these partnerships?
I think commitment to equality is a starting point. Understanding that by addressing these issues, we are actually addressing health inequality. So using any powers, any tools and language to articulate what the sector does already well, and to forge, to develop relationships with others would be responsibility, I feel, for governors as well as for the professionals working in the sector.
Thank you. Katina Barrett from Education and Intersectionalities is asking, if there are successful collaborations and adult learning offers for people with mental health problems in some areas but not others, how do we make sure that we're not adding to the postcode lottery that people with mental health problems already experience through mental health services?
I think the support of funding and policy support of this agenda is important. Agreeing the outcomes across, understanding the needs of localities would also be forming an important part of ensuring that we do not continue contributing to health inequality.
Throughout this, it seems to me that further education continues to get more complex. And sector leadership, as FETL so clearly demonstrates, needs to be strong and resourceful. How does strong and resourceful leadership fit with this new mood of collaboration?
Going back to my previous points, I think realizing that the challenges at the minute go beyond organizational boundaries, and that leadership focus has to take account of the outside world and be mindful of their own organization within that. And therefore, relating to other parts of the system, learning from other parts of the system is a key. And this is where collaboration actually sits in.
Now, a question here. The further education sector collects a lot of data to demonstrate the outcomes for learners. What impact would the collection of yet more data have on the quality of students' experience? Are we not just going to drown in a sea of statistics?
Well, I wonder whether we use effectively the data that we currently collect. And I think looking at what we are currently using and what could be used in order to share the narrative with other partners, in order to support people's well-being and health, would be a starting point. So we may have to consider other outcome measures and reevaluate the extent to which the data that we currently use is actually being used effectively.
Okay, there's a linked question here. Everyone acknowledges that the sector's just incredibly busy and under-resourced. Why should we be expected to take on work mobilising, inspiring and empowering policymakers and NHS providers?
I think the starting point here is really that we are already supporting our local communities that may be facing difficult social, economic or environmental issues that actually impact on their health. The question is, how efficient are we in supporting them? Are we actually, the two sectors, mental health sector and adult education, are we actually being wasteful of the current resources? Could we be more efficient if we were working together? So I think this is also about maximizing our impact, as well as knowing that we are actually bringing a social value by addressing these social determinants.
Okay, well, I have another question here, and I think we're going to have to make this the last question, but it's a sort of fairly sweeping one. How would you describe the skill set that leaders in further education require to promote such collaborative activity?
I believe that leaders need to be humble, to understand what it is that they don't know, to have humility, to reach out, learn from others.
Well, that's a suitably challenging thought. OK, thank you very much, Dragana.
Thank you, Paul.
And thank you for being with us. The broadcast will be available on the FETL website, and so please bring it to the attention of colleagues and those who you think might be interested in this splendid presentation and our subsequent discussion. And we're going to close with just a short clip summarising Dragana's research.